Hello, good evening. My name is Ann Gillenwater, and I'd like to welcome you to our webinar. I'm going to share a few introductory slides, and then we'll get on with the speakers. All right, so the title of the discussion today is on HPV-related oropharyngeal cancer and the importance of early detection and prevention. This evening tonight was organized by the Cancer Prevention Service of the American Head and Neck Society, as well as the Survivorship Service, and also in conjunction with the Head and Neck Cancer Alliance. I would like to do a shout out to Hoffman LaRoche, who are kindly providing the educational funding for this session tonight. HPV-related oropharyngeal cancer, we feel, is a very important topic. There's been a very marked increase in incidence in the United States of oropharyngeal cancer over the last few decades. And although the treatment is highly effective, the treatment can produce significant long-term sequelae with loss of function in a vital area. Therefore, we will like to show you that early recognition of oropharyngeal cancer in the primary care setting may be a great way to improve outcomes for patients with this disease. So the objectives of the session are outlined in the flyer, but I'll go over them briefly. First, we want to provide information so that you can identify current trends in the epidemiology of HPV-related oropharyngeal cancer. Also, to be able to recognize common clinical presentations of HPV-related oropharyngeal cancer, to distinguish short and long-term side effects that come with head and neck cancer treatment, and to be able to articulate current barriers to population-based screening for HPV-related oropharyngeal cancer, thus emphasizing the importance of primary prevention. And finally, to be able to outline current indications for HPV vaccination and the roles that vaccination can play in prevention of HPV-related cancers. So we have a distinguished panel of speakers today. We'll start off with Laura Dooley, who is an assistant professor of head and neck surgery at the University of Missouri. She's going to be speaking on epidemiology, clinical presentation, and challenges of screening for HPV-related oropharyngeal cancer. Next, we'll have Dr. Warren Swigel, who is a head and neck oncologic surgeon in Pittsburgh, Pennsylvania, and he will be speaking on treatment approaches and expected side effects for HPV-related oropharyngeal cancer. Then we will have Dr. Kristen Oliver, who is both a pediatrician and an environmental medicine and public health faculty at Mount Sinai. And finally, we will finish up with Dr. Michael Murphy, who is a neuroscientist and a psychiatrist at Harvard, but is actually also a survivor of oropharyngeal cancer and is an ambassador for the Head and Neck Cancer Alliance. So this is our disclosure slide. To the best of our knowledge, we have nothing to disclose. And then that will be the end of my brief introduction. I think we're going to move now to some questions to see if everybody in the audience is still awake and able to interact with us. So the first question is, what is the most common HPV-related cancer in America? Cervical, anal, throat, oropharyngeal, or penile? And go ahead and respond if you're able. The second question is oropharyngeal cancer more common in men or women? And the answers could be men, woman, or it occurs in the same frequency in both men and women. And the third question is, which of the following is the most common presenting sign or symptom of a patient with HPV-related oropharyngeal cancer? And the possible answers are ear pain on the side of the cancer, a neck mass, difficulty breathing, coughing up or spitting up blood. Okay, so it looks like for the first question, most people, 56% picked cervical, whereas 42% picked oropharyngeal. For the second question, is oropharyngeal cancer more common in men? 81% said men. And for the third question, 84% said a neck mass. And so I hope we can review all these in our talks today. And before we move on to our first speaker, I just want to again thank all the audience participating in this seminar, as well as the American Head and Neck Society, as well as the Head and Neck Cancer Alliance, and of course, Roche for the funding to allow us to present tonight. So let's move on to our first speaker. That's Dr. Laura Dooley, and from the University of Missouri.
Hello. Thanks for having me and allowing me to come talk to you all. So yeah, those three questions, I was hoping we weren't going to go over the answers too much because that's what I plan on doing, and I didn't want to feel not have anything to talk about. But the epidemiology for head and neck cancer, or in general, has really been related to tobacco use and alcohol exposure in the past. However, the last 30 plus years, especially in the oral pharynx, we've noticed with smoking cessation that our numbers of head and neck cancer, oropharyngeal head and neck cancers, has actually been increasing. And that's pretty much due to the new increase in prevalence of HPV. So during that time frame, we really noticed about a 225% increase in the population increase of HPV positive oropharynx squamous cell carcinoma. And since then, there's been at least been a 5% annual increase yearly, annual, and it's now actually more common and has a higher incidence than cervical cancer. All right. And we know HPV is one of the most common sexually transmitted diseases, and it's causing or is implicated in about 71% of the oropharyngeal cancers now seen in the US. And this does vary by geographic location. So it's even higher in Sweden, according to some reports, and in the more developed countries in the world, this is a big cause of oropharynx cancer. However, in less developed countries, we're still seeing mainly the smoking and tobacco exposures form the HPV negative oropharyngeal carcinomas. Because HPV is such a common infection, at any given time, almost 10% of our population is infected, and most people have been exposed to HPV at some site during their lifetime. However, the vast majority of people will clear the infection and are completely asymptomatic from the infection and will clear the infection when they get it. However, over decades, 10, 20 years, some people don't clear that infection and can have changes in their mucosa that go from mild to severe to invasive carcinoma over time. And I love this tweet, so we threw this in there as well. With human papilloma, its most common sexually transmitted infection is cause of almost all cervical cancers. And this can translate over as well to our oral pharynx cancers. So, we do find, though, that men are still our #1 patient population, and they're affected with this about in a 3-to-1 ratio to women. The thought is that female genital mucosa may have higher loads of HPV, and it's easier to transmit with oral sex from females to males to cause an infection and then subsequent cancers. We also find that there's actually a lower immune system clearance of the HPV virus by men. So so there's a higher seroconversion rates for women that are higher than men. because there are tons and many different subtypes of HPV, the vast majority of HPV infections are caused by HPV, or the ones that cause cancer, sorry, are caused by HPV 16. And we're finding that the increased risk of infection and then cancer also will increase with the number of oral sexual partners that you have. And this is probably just different subtypes and more exposures. But if you've had 6 or more oral sex partners, your risk of HPV will double. And actually, this will continue to increase with sexual partners, and it will increase your risk, especially if you're a male. In the female population, it usually levels off after about 5 to 6 partners, the risk will level off. However, in men, that risk will continue to increase to approximately about 15. So yeah, who is the typical patient? So far, it's usually this cancer is affecting a little bit younger population, usually middle-aged instead of our older smoker, drinker, 60, 70-year-olds. And we're finding it's being seen in patients who don't have the smoking history. They may not have, or they're a smoker, but don't have 100 pack years, 20, 30 pack year history, or the non-smokers. This is predominantly seen in more Caucasian men and those with higher socioeconomic status and higher number of sexual partners. All right. And our typical presentation, all of those that we talked about on that question are symptoms that a patient may complain of: ear pain, some trouble swallowing, pain with swallowing. But usually the most common patients come into first is this neck mass. They've noticed, oh, their turtleneck doesn't fit anymore in the winter, or they're shaving and they hit a lump there. The mass is usually firm. It's higher up in the neck, or in level 2, right behind your submandibular gland in front of your sternocleidomastoid muscle. And this mass is usually firm. It's not always fixed. It's not always stuck or non-mobile, but it's usually pretty firm and feels like a marble in there. On imaging, it can look cystic. A lot of times it can look and show up similar to a brachial cleft cyst as well. And these patients, they can have some smaller primary tumors. So it's harder to see them when you look in the throat, and that may not be the first thing they even complain about, is a sore throat or a mass in their throat or bleeding or anything like that. The vast majority of time is the neck mass is what pops up first when you talk to them. So, and then my other topic was screening, because this is HPV infection is such a common sexually transmitted disease, and it's becoming more and more common to see as a cause of cancer. Why aren't we screening? Or is there a good way to screen? We have a screen for pap smears. Why can't we do that for oral cavity cancer? And right now, we're not there yet. All right. We don't have a good way to detect precursor lesions or a very early stage lesion. If we think about the oral pharynx, you have your tonsils and your base of your tongue in that area, and that's all made up of this lumpy, bumpy lymphoid tissue. The HPV virus and the changes to that mucosa can start anywhere in that lining, in the crypts, in the kind of caves in those tonsils. So it's not a nice smooth area that we can sample easily. It's a pretty broad area. And then we also, even if we could find these cancers earlier, or even before they become a cancer, we don't have a great way to treat that. We don't have anything to reduce the incidence of these dysplastic lesions turning into cancer, or decreasing the overall morbidity from this. In a perfect world, we find all the cancers very early, and they can get limited treatment, but we don't have anything on those pre-cancers yet to try and help treat and prevent them from turning into a cancer. All right. Specific things with screening that I kind of mentioned: location, multiple subsites. And while we do say that the risk of HPV positive oropharynx cancer is increasing, it's still in the whole population pretty low. It's still a pretty rare cancer. And probably more than 22,000 patients a year are diagnosed with this. And this number is getting a little bit larger, but that's still pretty low. So you would need to screen at least 10,500 patients to detect one cancer. And in this, we can probably improve those numbers by just screening higher risk populations. But right now we haven't truly identified the true high risk population. We have our white males in a certain age group with increased sexual partners, but is there a blood test or something that we can do for the people who are holding on to their, haven't cleared their HPV infections, or people who still have antibodies to HPV that haven't cleared any of this? That may be a way to truly try and limit the people that we need to screen to try and bring down the incidence, to bring down the number needed to treat to help with screening. So right now for screening, maybe someday, once we kind of improve on a little bit of our methodology and our ability to screen, or our ability to detect HPV in the blood and cancer a little earlier. But I don't think it's ready for prime time yet. But maybe someday we'll be able to have a screening test for this. So.
Well, thank you.
Hopefully those answered those questions a little bit more.
Thank you very much, Dr. Dooley. I think we have one more audience question before we move on to our second speaker.
Okay.
Okay. According to a 2018 national survey, what was the top reason that patients or parents did not pursue HPV vaccination? And your choices are concerns of side effects, concerns of efficacy, my child is not sexually active, not needed, not necessary. So go ahead and put in your choices and we'll see those in a few minutes. All right, so pretty good mix up here. But the winner was my child is not sexually active. So we'll deal with the answers to this, or the opinions on this, in the future talks. I think we can move on now to Dr. Swagel, who's a head and neck surgeon in Pittsburgh.
Good evening. My name is Warren Swagel. As mentioned, I'm a head and neck surgical oncologist from Allegheny Health Network in Pittsburgh, Pennsylvania. And today I'll be talking about and providing context on the treatment approaches and possible and probable side effects of treatment. Now, I'll be doing this under the scope of providing context for those people who do not normally treat head and neck cancer, but also provides the clinical context for the side effects, while our patient perspective will be provided later. So as mentioned, I have no disclosures. And so what I'll be talking about today specifically is treatment for curative intent. When we think about cancer treatments, we think about treatment for cure or for palliative purposes. I'll be focusing on curative intent. And so when we make our treatment recommendations, just to kind of frame the discussion, there are three main things, at least, that I approach a patient with. And one is, very first, seems obvious: remove the cancer that's there in some fashion. The other thing we have to think about is, how do we prevent this cancer from coming back? And some of the treatment options we choose not only are there to remove the cancer, but also to help prevent recurrence. And then the last piece, the last part of that balancing act, is trying to limit side effects. We can be very aggressive with treatment in many different ways, but does it make sense all the time? Or can we scale things back in order to limit some of those side effects? And so we really try to find that sweet spot for each individual patient. And so in general, most cancers have several different options with regard to treatment: surgery, radiation, and/or chemotherapy. Now, for head and neck cancer patients, or patients who have an HPV positive squamous cell carcinoma of the base of tongue or tonsils, really there's two main treatment pathways that tend to be offered. One is either upfront surgery, sometimes followed by low-dose radiation, or no surgery and a primary radiation modality, sometimes with or without chemotherapy. Now, the main treatment recommendation may vary based on several different things. One is obviously effectiveness. Radiation is going to be more effective than surgery. Even as a surgeon, I'm going to recommend radiation. Tumor stage and location are also important when we think about which treatments we recommend. Tumors that are easily accessible may only be able to be, or may need to be removed with surgery alone. And so we may offer surgery instead of radiation. Where higher stage or locally aggressive tumors, surgery may not be a great option compared to radiation because of the morbidity of surgery. That plays into the risks and side effects of these options. And lastly, when you have, the patient obviously has to make the decision in the end. And so, these are all discussions we have with patients, and eventually they have to choose, and it's up to them what the best option is. The other main goal is we really try to attempt to avoid all three treatments. I think that's an important concept, is the risks of side effects and known side effects and expected side effects really go up when treating a patient with all three modalities. And so we try to steer people or try to recommend options where we're only doing one or two treatment modalities. So from a surgical approach standpoint, like I said, this is kind of a broad view. The tonsils and the base of tongue are hard to get to. These are not areas that are easy to access to remove aggressive tumors. And so traditionally, the open type approaches were pretty large surgeries, pretty aggressive surgeries. They included things like a lateral pharyngotomy or lingual release, sometimes even having to cut the jawbone in order just to get back to the back of the throat. And you can imagine these can be aggressive surgeries. And so as surgery improved, most patients now, the vast majority of patients, if they're going to have surgery, tend to undergo a more or a less invasive approach, an endoscopic approach, either via transoral robotic surgery, or some surgeons use the laser and transoral or laser microsurgery. And these are all accessed directly through the mouth. Now, also with surgery, it's important to remember the lymph nodes. A lymph node dissection or a neck dissection is usually involved also with surgery. This is performed through an incision on the outside of the neck, and the lymph nodes removed, whether they're pathologically enlarged or not. And so from a surgery perspective, this is kind of what the operating room looks like. This is the older generation robot. You can see the robotic arms in the patient's mouth, and the robotic arms on the screen to the upper right, and then the surgeon sitting at the console, moving the robotic arms. As I said, this is the older version. The newer version of the robotic instrument uses a single port where all instruments go through that port. What this allows is the surgeon to see close up a magnified view of the tumor. This is a patient with a squamous cell carcinoma, HPV driven, actually of the midline back of the throat. This is not something that was easily seen when looking through the mouth, but you can clearly see the tumor under magnification and on the robotic screen. And then we're able to use up to 3 operating arms in order to resect the tumor. And so that's what we did. We cut around the tumor and elevated it off the retropharyngeal fascia, and we're able to obtain negative margins, no adverse features, and also performed lymph node dissection for this patient. Now, I talked about the other treatment pathway. That would be mostly radiation. This is usually done through intensity modulated radiation therapy, or otherwise known as IMRT. This is done with external beam radiation using 3D conformal techniques, image guided. Basically, the radiation oncologist can use some imaging modality, either MRI, usually CT scan, and circle where the tumor is, what area needs to be treated, and in a sense, kind of paint on where those radiation fields need to be. And you can see the example here where the high dose radiation field is going to be around this tonsil tumor, and then where the lower radiation field is going. Now, these tend to be delivered in 2 gray per fraction a day. What that means is if a patient is receiving 70 gray of radiation, which is the dose of radiation, That's 35 treatments that oftentimes is five times a week for 7 weeks. Now, important to note, side effects are dose related. And so one of the main advances in radiation technology more recently is being able to reduce the dose, the primary dose needed to treat cancers from 70 gray to 60 to potentially even 50. As I mentioned, chemotherapy is rarely used alone for these types of cancers, at least when it comes to curative intent. It tends to be given with radiation as a radiation sensitizer, making the radiation work more effectively. Tends to be one agent given at a time, not multiple, and it can either be given weekly or 3 times during radiation. Now, moving to expected side effects and toxicities. We'll go over each one kind of in sequence. Now, mind you, these are short-term expected side effects and toxicities. We'll talk about long-term next. With surgery, biggest thing is pain. I tell patients it's 3 or 4 weeks of the worst sore throat of your life. And it pretty invariably is. You can imagine we're cutting into muscles that allow you to swallow. And so at least some limited dysphagia or potentially permanent dysphagia is a side effect of surgery. When we remove lymph nodes, shoulder weakness can be a disabling side effect due to circumferential dissection of the accessory nerve. And then bleeding, potentially even life-threatening bleeding, while rare, is a known complication of these types of surgery. For radiation, patients, again, pain, you're getting radiation to the inside of your throat. It's a sensitive area, so pain, mucositis. Again, the muscles of swallowing may be affected, so significant dysphagia could occur. And nearly all patients will experience at least some temporary change in taste as well as dry mouth. With chemotherapy, as I said, it's usually given with radiation and oftentimes makes the side effects of radiation worse. On top of that, depending on the drug given, hearing loss is a potential as well as peripheral neuropathy. Again, with regard, all of these treatments can also have long-term side effects. While the short-term side effects may improve over the course of weeks to months, long-term side effects can stick around with patients for the rest of their life. And in some cases, get worse as time goes on. These include things, again, like dysphagia. Again, we're cutting into muscles that affect swallowing, irradiating those muscles. And so patients can have permanent problems swallowing long-term. Again, when treated with high-dose radiation, these problems can get worse with time. We talked about hearing loss. This is not reversible. And again, xerostomia, one of the most common complaints for patients with head and neck or who receive treatment for head and neck cancer. This dry mouth xerostomia can be disabling, causing, again, worsening any known dysphagia, causing significant morbidity. Other things like lymphedema, again, while not as excessive as, say, a patient who has a lymph node dissection for breast cancer, lymphedema, the head and neck, again, can be quite limiting. Scarring, fibrosis. Again, we talked about neuropathy. For patients receiving radiation to the neck, many years down the line, they have to be monitored for carotid stenosis. And then other things we need to think about with almost any cancer treatment: financial toxicity, anxiety, depression, as well as things like insomnia can all affect patients in the long term. And so I don't want to go on too much further. And so when we think about what treatments to recommend for patients, it really is, we got 2 main options, either a primary surgery option or a primary radiation option. And it really is a balance and a discussion with the patient. And it's not just about, you know, who's having the discussion, but really about that patient who's in front of you, and telling them, okay, for you, this is what we need to expect, either with option A, option B, option C. And so with that, again, I'd like to thank the American Head and Neck Society and Head. Thank you.
Well, thank you very much, Dr. Swagel. Before we move on to the next speaker, I just wanted to remind the audience that if you do have questions, if you could submit them in the Q&A on your screen, and then we will try to get to them all at the end of the session. So our next speaker is Dr. Oliver, who's an associate professor of both pediatrics and environmental medicine and public health at Mount Sinai.
Hi, great, everybody. Thanks Thanks for inviting me. Happy to be here and talk. And it's always nice to sort of come in and do this is what we can prevent following all of that fantastic but intense information, frankly. And I think a lot about it as a pediatrician. We can prevent these diseases that we never see, right? So for pediatricians, I think it's incredibly important to understand what the effects are, both in terms of the cancer and the side effects. So I really appreciate hearing that tonight. And HPV, admittedly, is my favorite vaccine. And one of the reasons why is this. It's really neat to have been able to see how well the vaccine works and to watch that progression over time. So then it's different from other vaccines and other diseases. So here with HPV, first what we could look for is the vaccine in the real world. You know, we had great trial data, but in the real world, was it really preventing infection, right? Just HPV prevalence, looking at prevalence, cervical or oral prevalence, as well as genital warts. It takes a little bit longer before somebody develops, cervical precancers, which we can detect and look at the effectiveness there. And then finally, decades later, you can actually look at HPV associated cancers and the effectiveness there. And since this vaccine has been out long enough now, we have data for all of that. And that's what I'm going to share today. And so starting with just prevalence of HPV vaccine, this is an interesting study that they've been doing for a while now using AHNS data, National Health and Nutrition Examination Survey, national sample. They do a lot of things in AHNS, but one of the things they do is have women collect self-cervical swabs and have been typing it for HPV before the vaccine came out and then following it over time. And what you can see here is this really big drop in the prevalence of HPV types, and these are the 4 types that are most commonly caused in the cancers and that are prevented in the vaccine. You can see for people who are age 14 to 9, this dark blue purple here is the prevalence before the vaccine was introduced. And then as we go along later and later after the vaccine was introduced, meaning both increased immunization rates, but also longer time to have an impact. And for this age group, 14 to 19 years, 88% lower prevalence in the most recent study looking at HPV prevalence. Again, we see also big drops still in the 20 to 24-year-olds, not as much as you look at the older age groups because they were not, they did not have as many options and the time to be vaccinated and to prevent infection with these types. So that's great early data in terms of looking at just the prevalence of disease. There is some similar data for oral HPV infections. So there was one study that found, looking at adults who had had at least one HPV vaccine dose, prevalence of oral HPV infections was similarly 88% lower in that group compared to people who had never received any HPV vaccine. So good early evidence that we're going to have, if you get rid of the infection, there's no HPV there, downstream, you can, eliminate those precancers and then the cancers. And this is what we really care about a lot, right? Is the actual cancer diagnosis. Although I'll have to say specifically for cervical cancer as well, those precancers, which are detected early, can, also cause a significant amount of morbidity, and the impact of that diagnosis and the treatments is significant as well. And those are big numbers. But this is a study out of, and I want to say Finland, but it's one of the Scandinavian countries where they have really great registries, both for immunizations and for cancer registries. So they can track you basically from the moment you were born, right, and follow you forever. And so that's what they did in a happy, healthy way. And so this was looking at women comparing women who had been vaccinated with HPV compared to those who had not, followed them for 10 years, and then looked at the rates of cancer. And you can see in this group of women who were vaccinated with HPV vaccine, there were no cases of these HPV-associated cancers, cervical, vulvar, and they're also oropharyngeal, right? So great evidence that we are preventing the actual cancer compared to the non-vaccinated women where you did see HPV-related cancers develop. They did the fancy calculation, it came out to a vaccine effectiveness of 100%. Realistically, there's a wide confidence interval. It's probably not 100%, but it's still very good. And so this was really great news and exciting that we're at a time where we can see this type of data. The key here for all of these studies, and you may have picked up on it, is that the effectiveness depends on getting this vaccine in on time. And I'll talk a little bit about what that means in a minute. But you can see evidence of that here. This is, again, another cohort study in another, I believe, Scandinavian country, looking at invasive cervical cancer based on vaccination status. And so here, and this is age, they follow this cohort, if they got vaccinated or not, through time. And you can see here, they start to diverge. In orange, women who have been unvaccinated, right? You can see that rate of cervical cancer going up and up and up. In blue are women who have been vaccinated between ages of 17 and 30 years. So we are preventing invasive cancer, but not nearly as much as if they had been vaccinated at age less than 17. But that is a really big difference. So rate of cervical cancer, 88% lower among women who are vaccinated before age 17 compared to never vaccinated. And so starting to think about really the importance of getting this in on time. And you'll hear me in a minute talk about how 17 is still not on time, right? That we want everybody to be fully vaccinated by the time they turn 13. And why is this so important, right? It's really about preventing infection. And when is the key time to do that? So you can see here, and this is specifically for genital, but it works, the same way for oral. You can see here in green is, when we see HPV infection occur. This is population prevalence over time. And this, it starts, let's say somewhere probably around 13, 15, right? And it really starts to peak in the 20s. It takes, decades later or years later to develop the precancers and decades later to get to the full cancer. If we vaccinate here, we're preventing all these downstream consequences, right? That you can prevent by preventing all these infections. And so that is the key to it's about when someone is exposed for the first time to HPV and preventing that. And we know for adolescents and children, it's not just about intercourse, right? It's about all the other activities that they're doing, any type of oral, genital, anal, et cetera, contact that can transmit HPV infection. So you've really got to think we need to get this in as soon as possible. And that's why, both for the National HPV Vaccination Roundtable, the American Cancer Society, American Academy of Pediatrics, we're all starting to think about really, let's start vaccinating at ages 9 through 12 thinking about that as on time. The guidelines are to do routine, according to CDC, are to do routine vaccination at ages 11 to 12, but you can start at age 9 or 10. AAP and American Cancer Society are saying, we really should start at age 9 because there is, and I'll talk about it, there's really no downside. It increases your chances of getting that vaccine in and done. And so thinking about age 13 on, you should be complete by then. You should certainly still vaccinate if you have a patient who comes in at that age and is un or incompletely vaccinated all the way up. But really, let's get this vaccine in any chance that we have. And I'll take a second to talk about that a little bit more. And the idea here is really that we know that if, there's a little data now and we're pulling together a lot more that's looking like if you start at age 9 to 10, not surprisingly, you're going to end up with higher on-time vaccination rates. On-time vaccination defined as completing the series by age 13, both according to CDC and some of the other measures that health systems are ranked on based on completing vaccine series is on time. And so if we complete more kids on time, we're going to prevent more of these cancers downstream. So let's not miss any opportunity to do that. And that opportunity can start when someone comes in at age 9 or 10. So you've got more times to complete the vaccine series. You're more likely to finish prior to their first HPV vaccine exposure. I talk to a lot of people, we don't know, a lot of times, our pediatricians say to me, I know like my patient population, they're just not those kids, they're not at risk. I know these kids. But the reality is like, I do not have an app on my phone that I can put in some specific markers and know which kids and which teenagers are going to be more at risk and have earlier sexual activity. So let's just prevent it in everybody and not worry about maybe I missed somebody. The other nice thing for me as the pediatrician introducing this, anecdotally at ages 9 and 10, there's just not as much of a need to talk about sexual activity because the parents aren't really there yet with a 9 to 10-year-old versus an 11 to 12-year-old sitting in the office, right? They're just not, they haven't started thinking about that yet. So it really takes that whole component away from the conversation. The other thing it does is fewer shots in a visit, which the adolescents really like too. Nobody wants 4 shots when they turn 11 or 12, right? When you're thinking about Tdap, HPV, meningococcal, maybe flu, maybe COVID, right? So let's start earlier so we have more time. And then often we'll hear like, oh, I just want the ones that are required when they come in at 11 to 12, meaning for school, they want Tdap and meningococcal. This way we've separated that conversation. Today, Charles turned 9 last week. That's great. We can start with the HPV vaccine series today. And that's just where we are. I do want to say, it's like, how are we doing with this vaccine? So this is sort of good news, bad news slide. So here we're looking at all of the vaccines that we give to adolescents and the coverage estimates for ages 13 through 17 nationally. At the very top are Tdap and meningococcal vaccines. So they're almost 90% at this point. And then down below, if you go down and down, then you get to HPV vaccine, 1 dose of HPV vaccine, right? Hovering somewhere in the 70s at this point. And so we have a lot of opportunities here where we've missed the chance to give HPV vaccine to adolescents who have gotten obviously their Tdap and their meningococcal vaccine. So we have been doing a lot better over time. Like this continues to increase every year, which is great. But we still continue to have this gap between the other vaccines. And then when you look further down at up to date, meaning did somebody receive either 2 or 3 doses based on the age they started, we're hovering around 50%. So we really have a lot of room for improvement. And again, this is 13 to 17, noting that we really want everybody to be done complete by the time they're 13. So these numbers are lower when you look just at 13-year-olds as a group. So we have a ways to go. So what's going on? And this was one of the poll questions. But so why isn't everyone as excited about this as I am and accepting this vaccine? So in addition to looking at the immunization rates in these studies, they've also been asking parents of kids who haven't been vaccinated, why not? What are your top reasons for not having your son or daughter vaccinated? And now you'll find out number 1 here, and this is the latest data they published this for was 2018. But here at the top is, parents saying it's just not needed or not necessary, right? And so is that, there isn't a lot of detail here, but is that because people don't understand, is it for males and they don't understand about the risk for oropharyngeal cancer? There's something about sexual activity tied into there, unclear, but, and that really hasn't been changing that much. So, we really need to do a better job there. More concerning for me is that over time, what's been increasing are concerns about safety. Right. So even though we've had more and more data about how safe this vaccine is and more time to study it, that's rising as a concern about reasons not to be vaccinated. And this was all pre-COVID. And so we know that there have been increasing concerns about the safety of vaccines since COVID vaccine came out. And so that I'm really keeping an eye on. Not recommended has been going down, so that's good, but it could still be a little bit higher. Lack of knowledge and my child isn't sexually active are both lower. So there's room, we can think about where there's room for improvement here. In case anybody's wondering, is there a legitimate reason for people to be concerned about the safety? Let me just be very clear. It used to be that I would say this was the best vaccine. We've studied this more closely than any other vaccine. Now I think COVID has taken the place of that in terms of intensity, but not in terms of time, right? So, I love this tip that the HPV vaccine has been out as long as Twitter. Right? This is an old vaccine. Like it's so old. So we have a lot of data on it, and we really do. There have been so many studies, and these are all of the things that are not associated with HPV vaccine, right? So all the things that people might have been concerned about at one time, we really have excellent data that we do not have to worry about this. Anaphylaxis, stroke, blood clots, thromboembolism, all sorts of autoimmune disorders, primary ovarian insufficiency, right? Infertility concerns, not at all linked to HPV vaccine, as well as a number of other conditions. So there is really, really good data on that. And I did want to highlight one other thing about where we are in terms of coverage. So this is specifically looking at 1 dose of HPV vaccine by age 13, which is really what we want to, at immunization information system. So these big registries across the country. And specifically, let's look at 11 to 12-year-olds here. This is 2018, so we went from almost to 50%, and then you see 2000 and 2019, then you see 2020, 2021. So this is probably, looking at the early impact of the pandemic and seeing rates start to drop. We know people stayed home. We know they didn't come in for routine care, especially in this adolescent age group, and doses were missed. CDC has ordering data on this, looking at how many orders of HPV vaccine happened in these different years. So this was 2019, a typical year in terms of in millions, the number of doses of HPV vaccine ordered. Here's this big drop due to the pandemic in 2020. It still was lower than baseline in 2021. In the first half of 22, it's still down 10% compared to 2019. And so, but what you need to see, we don't want it just to come back to normal. We have to go above that because we missed all of these doses. There's something over 1 million doses of HPV vaccine. from the pandemic. And that is a partial generation who is at risk for all of these cancers now. So we've really got to think about upping our game in terms of recommendation, getting kids back in, and increasing every opportunity to vaccinate, starting at 9, well visits, follow-up visits, acute care visits. So I'm asking and begging everybody, no matter what your role is, you're a provider, you're an educator, you're in public health, you're a systems manager, think about right now, as people are coming in for those well child checks, for all those forms to go back to school, making sure that we prioritize adolescent immunization, in particular HPV vaccine, doing some reminder recall, getting them back, and getting as excited as I am to prevent cancers in this population. All right.
Well, thank you so much. That was great. Great talk.
I knew I could get us back on time too, if anybody can talk quickly.
All right. All right. And we're going to move on to Dr. Murphy, who is a head and neck cancer survivor and is also an ambassador from Head and Neck Cancer Alliance.
Thank you very much. I hope everybody can see my screen. Today, I'd like to talk with you a little bit about the impact of HPV-related oropharyngeal cancer and give you a patient's perspective so that hopefully you appreciate that this cancer, with its relatively good prognosis, is still really serious and we should really make consistent efforts to minimize its impact. My story begins back in May of 2020. I woke up one morning with a very mild sore throat on the right side of my mouth. And normally I would have just ignored it. But ever since COVID happened, my workplace had initiated an attestation form. So I had to say I had no symptoms which could have been COVID, or I couldn't go to work. And the sore throat meant that I couldn't go to work. So I did a few days of saltwater rinses and caught up on some paperwork. But the sore throat didn't really improve. I called myself in an antibiotic. I finished the course of that. And the pain got a little bit better, but was still present. And I began to notice a swelling in the back of my mouth. I talked to a friend of mine in ID and tried a different antibiotic. And the pain did eventually go away, but the swelling got worse and worse. And it got to the point where the swelling was so large that I could no longer sleep on my side. My airway would be occluded and I'd wake up kind of coughing. This was really worrying to me, worrying to my wife. At this point, I thought maybe I have some sort of unusual, abscess or something. And so I went to the local urgent care to see if they could drain it. They couldn't drain it, so they sent me to the ED. At the ED, the ED doctor and the nurse, tried to express some fluid. They got a little bit of blood, but not much else. And so they set me up with an appointment at the ENT clinic for the next day. The doctor in the ED told me, well, they'll probably want to get a head CT. So let's just get one now, as long as you're already here in the hospital. And I said, sure. And that was the first of what turned out to be many CTs for me. After the CT, I went back into the little patient bay and I waited and I kind of repeatedly checked the EMR to see if my read had come up. And finally it did come up with a little red exclamation point next to it. And so I clicked on it and this is what I saw. And this is what it said. 3 centimeter right posterior oropharynx mass and a 3 centimeter right cervical lymph node, highly suspicious for malignancy. Now, I'm not a radiologist, but it's pretty clear that this large blob in the middle of my airway is not supposed to be there. I remember feeling just panicked when I saw this. And I remember thinking, okay, maybe this is some resident or intern, making a really bold call. And so I looked up the person who wrote the read. Turns out it was the head of the department, so knew what they were doing. I began crying in the ED bay, and then I had to go home and tell my wife and my children that I had cancer. And that began this other stage of the journey, the second stage, from diagnosis to treatment. So at this time, I didn't know what kind of cancer I had. It could have been HPV oropharyngeal cancer. It could have been non-HPV oropharyngeal cancer. It could have been lymphoma, lots of different things with different sorts of prognoses. And so I made it to that ENT appointment the next day, and they numbed me up, and I had a biopsy, and I had a lot of labs drawn. This is the chair that I sat in when they took the flexible endoscope and put it up my nose to look around to see if they could visualize the cancer. And once we had some more information, I had a PET scans. This is me getting infused with radioactive glucose so we could look for distal mets. Fortunately for me, I didn't have any distal mets, although I did have bilateral lymph node involvement. And ultimately, I think it was stage 2. I wasn't really sure what I wanted to do. I'd read a lot. I knew that the treatment about this was sort of standard for a long time, but there were some clinical trials that were going on to try sort of less aggressive treatment. But ultimately, I decided to go with the basic standard treatment at the Dana-Farber Cancer Institute. And that was 3 boluses of cisplatin. Cisplatin is a very effective, but quite nasty chemotherapy agent. and 70 gray administered over 7 weeks. I just want to show you this this clip. This is a sped up version of me getting radiation. I just wanted to show people what it's actually like. So I'm lying on this bed with this plastic mask that goes down to about mid-arm, and it's pinning me to the table. I had always struggled with claustrophobia, and so I did some meditation practice to kind of make myself be able to tolerate this better. And by the end, I was. But again, I'm lying there on the table. This machine is rotating around, making all sorts of loud, intense noises while the radiation techs are, kind of safely in the next room. I did this every day for 7 weeks. A lot of other things happened during treatment. So one of the first things that happened was that I began to lose my sense of taste and my sore throat got worse. I had talked with my doctor about this. I kind of knew what was coming, and we agreed that when I began to not eat as much, I would get a PEG tube. And so this is me flushing out my PEG tube for the first time. I was 39 when I got sick, and I had a 9-year-old daughter and a 5-year-old son. And they, of course, were absorbing all of this. And I wanted to normalize it as much as I could. So this is my daughter and my son both feeding me through my PEG tube. I began to look different. So before this whole thing happened, I had a pretty big beard, and I was proud of the beard. I liked having it. I had it for years, and I kept it for far too long as it became patchy and scraggly. I also lost hair in the back of my head, as you can see, which gave me the appearance of having a very strange haircut. Many times I was deeply, deeply fatigued. I spent days lying in bed like this, barely awake, especially 2 or 3 days after a chemotherapy dose. And in addition to spending most of the time sleeping, losing my hair, losing my beard, and not eating, I developed a really painful red sore throat. It looked like I had just applied sunscreen to every part of my body except for my neck, and sat in a tanning bed. So after 7, miserable weeks, treatment did end, and we were all very excited. My son was in the middle of a Nate the Great phase, so he's dressed as a detective, and this is the mask that I wore in radiation. And treatment was over, but my experience of cancer and my experience of what it means to be a cancer survivor was actually just beginning. Several things happened or continued to happen, and I kind of divide them in my mind between minor issues and more serious things. So for the minor issues, my beard never really came back. It fell out, and if I try to grow a beard again, it's patchy. Not a big deal, but it is a change in my appearance. This thing that this woman is wearing, this is a mask that I own because I have lymphedema from my treatment. And so I wear this mask every once in a while to sort of push the lymph fluid out of my neck. Otherwise, I have a kind of a drooping neck. This picture in the middle, this is not my belly button. This is the scar from the PEG tube, which I say just another example of my appearance being changed and also potential site for adhesions or other complications in the future. More annoyingly, several times a day, I get very painful neck cramps. They kind of shoot from the back of the base of my skull up into my jaw, usually my lower jaw. It can happen when I'm talking or when I'm eating, and I can usually talk through it. It only lasts about 30 seconds to a minute, but oftentimes I have to stop and hold my neck. One of the most common side effects of the treatment for this kind of cancer is dry mouth, and that certainly happens to me. So foods that I traditionally really enjoyed, like this Vietnamese rice noodle bowl here, I don't enjoy the same way because it's very hard for me to swallow without a great deal of liquid. In addition to the change in how I make saliva, my taste buds changed. So my taste did eventually come back. It took, I would say, 6 months to a year after treatment for them to fully come back. And they're fundamentally different now. So things that I really enjoyed eating, like, for example, chocolate, no longer taste good or no longer taste as intense. And that's going to be the way it is forever. But taken together, these are all minor issues. More serious are the complications of dry mouth. So this picture here is my toothbrush. These are my special toothbrushes that I have to order off the internet. They are super soft because I have less saliva. I am extremely liable to having things like cavities, etc. This is my fluoride prescription toothpaste, which works really well, but will also eventually discolor my teeth, giving me brown teeth. And this is my fluoride gel, which I put in trays, which I wear at night. In addition, I see the dentist 4 times a year. Insurance only covers 2 of those, and so 2 of those I'm paying out of pocket, which brings me to the next kind of complication, which is financial toxicity. I have this picture here. This is a pillow, and the reason I have this picture is to remind me that when I got sick, I was concerned about the financial repercussions of going on disability for my family, and so I didn't. And so my wife got me a pillow like this so that I could see patients on Zoom while lying on the couch or lying in bed. And I can remember doing this and occasionally, having to stop an appointment because I was too physically ill to continue. I think over the course of my 7 weeks, I maybe took 3 or 4 days of vacation. Something else that I noticed was that I was using this Kate Farms tube feed. Now, this is a very nice, very nutritionally balanced, very, organic tube feed product. And I was using 4 cartons a day because I wasn't eating anything. My insurance covered it, but if it hadn't, I would be paying about $9 per canister. When I finally got my PEG tube removed about 3 months after treatment ended, I went to this webpage called the Oldie Foundation, where if you have extra Kate Farms or other tube feed products, you can post them and people can come pick it up. When I posted that I had a box of extra Kate Farms in my basement, I had people emailing me from Texas, from Louisiana, from New York, from all across the country. So there's a huge need for this stuff. It's incredibly expensive. I believe Dr. Swigel mentioned hearing loss. So on the left here, this is my audiogram pre-treatment. And if you haven't seen one of these before, on the y-axis is your decibel hearing threshold, and on the x-axis is the frequency. And anything below, 25 to 30 is considered mild hearing loss, and it gets more severe as you go down the graph. So I had fairly average hearing, maybe a little bit of kind of borderline hearing at the highest frequencies. But after treatment, I have, moderate to severe hearing loss at high frequencies. Practically, what this means is that if I am talking to someone, I can understand that they are talking to me. And if I'm looking at them, I can almost always make out what they're saying. However, if there's anything else going on, or if they're not facing me or I'm not facing them, I have a great deal of difficulty understanding what they're saying. And this is complicated by the fact that I have tinnitus, I would say, about 90% of the time. My own particular hearing loss is in this threshold where a hearing aid may or may not be helpful, but my audiologist expects my hearing will continue to worsen with time, at which point I will get a hearing aid. I also want to talk briefly about psychological effects, not just on me, which is, of course, what people might expect, but also on my children. So we encouraged my daughter to keep a journal while I was going through treatment. And here are some of the things that she wrote, and she allowed me to share this with the group today. I put this up to say that my daughter who was 9, was fairly aware of what was going on. She noticed when I was hiccuping after chemotherapy, and she noticed how I gradually got more and more fatigued from the treatment and was able to do fewer and fewer things by the end of treatment. My son, again, he was 5, he was a little bit less aware of what was going on. But I will say that for a long time afterwards, whenever he had any sort of mild injury or illness or cough or cold, he was worried that it was perhaps a harbinger of something more serious. And finally, I want to end with talking about the risk of recurrence and treatment sequelae. So the prognosis for this cancer is really, really good, but recurrences do occur. And so I, like many patients, undergo routine monitoring. I see my oncology team every 3 months at the Dana-Farber. I have repeat imaging, I have endoscopy, I have blood work. And I do worry that this cancer could come back and I could have to have additional treatment, which I can only imagine will be more difficult and worse. And then these are 2 treatment sequelae that I myself have experienced. So this is my TSH, which went from 2.3, which is within the normal range, to 5.6, which is elevated. I expect that will get worse as well, and I'll eventually need thyroid supplementation. The risk of stroke after radiation is also elevated. And so I get regular carotid ultrasounds to at least monitor that, and hopefully I don't need a carotid endarterectomy. And with that, I hope that I've convinced you this is a really serious and important disease, and we should do everything we can to prevent it. Thank you very much.
Well, thank you, Dr. Murphy. That was excellent, and I'm sure we all appreciate the patient perspective. We're run out of time, but if people are willing to stay over, we could go through a few questions and answers. If there are not any more from the audience, I can bring up some of the ones that were put into the Q&A. One was a question I think would be best to Dr. Dooley, was what are some good screening questions that dental providers or primary care physicians can ask to help pick up oropharyngeal cancers?
I actually think that's a hard one. But if they actually come in with a neck mass, that I would think to try and elucidate, is this just a normal enlarged lymph node versus is this something concerning? would be one of the best, some of the best questions would be more like, how are your teeth? Can you find a different source of this infection? Is it do you have a peritonsillar abscess or a tonsil infection? Did you have recent other illnesses? If that answer is no, and you can't explain why that neck mass is there, then after a pretty quick trial of antibiotics, definitely refer them on to ENT if it doesn't go away. On someone who you're just trying to see if they're more of a high risk patient population, I think you go by their demographics, as well as you can ask them sexual activity, if they've been vaccinated in the past, and go from there with their symptoms and their questions.
Okay, great, thank you. I think we have one more, which maybe we can direct to Dr. Swagel, and that is, why is it acceptable to have close margins during transoral surgery for oropharyngeal cancer?
That's
Sorry.
yeah. So the data would suggest, especially for HPV positive cancers, it has to do with, or at least thought to do with how they grow, whether there are little microscopic podocytes that shoot out of the cancer, or whether it tends to grow in a more kind of balloon-like fashion. And the data would suggest that you can keep close margins for HPV-related cancer because of that, potentially because of that type of growth, where we see less rates of recurrence, even with close margins. So without getting too much into it, I hope that answers the question.
Okay. And then I guess I have one more, probably back to Dr. Dooley, which is for patients seen in primary care offices with a neck mass, what duration of the symptom would make you worry about cancer?
Oh, probably if it's been there a couple weeks, and mainly if it hasn't, you don't have a reason for it. If you can't explain it. And if it's been there, it's been solid for the last 2 weeks, hasn't fluctuated in size. And even if you do get a little bit of fluctuation with antibiotic usage, I would still be concerned if it hasn't gone away within that 2 weeks or after that round of antibiotics. So some people ask, well, what should I order? Do you want a CT scan, or should I get an FNA before sending it to the ENT? But I honestly, if there's any doubt, I love to be able to tell someone, oh, that lymph node doesn't look anything anymore. Congratulations. Or getting a CT scan in our office. I'm jaded, I guess. I love the ones that are on our computer. They're easier to deal with, and then I have access to it forever. So I don't think you need anything specific before you get them to the ENT. Just the concerning neck mass is more than enough, or a concerning tonsil, or any concerning real lesion. So.
Great. And then to Dr. Oliver, what do you think is the best approach for helping encourage hesitant patients or parents to get vaccinated against HPV?
Yeah, I mean, the best thing is just this sort of announcement approach. So this is what we're doing today. Your child is 10, due for HPV vaccine. We can do that at the end of the visit. What questions do you have for me? So that is the most effective. It helps give everybody the sense that this is routine, which it is, and that most people are doing it, which they are. And conveniently for the pediatrician is short and sweet. If you have families that you know have been more hesitant in the past, or have already voiced some concerns, the focus now is on using some motivational interviewing skills that we have used in other settings, but now around vaccine conversations. So really just stepping back, taking a moment, do some reflective listening, try to understand their specific concern, ask permission to share the information that you have if they're open to that, and have more of a dialogue and conversation, not a debate or an argument, and know you have multiple times to talk to those families.
Great, thank you. And finally, Dr. Murphy, given your experience with your cancer, what would you say to those of us on the front lines talking to patients and parents about HPV vaccination?
I just think it's so important. I tell everybody I know with children or without children, actually, that the vaccine is extremely important. They should vaccinate the people they care about. And I just want to reiterate just how important this work is.
Well, that's great. I think unless we have some more questions, I'm just looking over the Q&A. If no one has any further questions, then I think maybe we can close this session. Well, I'd like to once again thank you all for participating in this session, and thank you again to Roche for the educational funding, and to the Head and Neck Cancer Alliance and the Head and Neck Cancer Society. So thank you very much, and thank you very much to all of our excellent speakers.
I just thank you guys for letting us talk. And Kristen, I loved your presentation. My kid is 8, so I had it in my head he would get vaccinated at 11, but guess what? He's going to come see you all in about a year.
You may have to remind your pediatrician that it is good to go at 9. So
They'll love it. They'll love it. So thank you very much.
My pleasure. Thanks, everybody.
Thank you.
Bye.